Hi, I'm Dr. Bibani, a third-year psychiatry resident at Henry Ford Behavioral Health. Today, I'll be talking about the QI project we carried out at KINGSWOOD Hospital, which is the Inpatient Psychiatric Hospital of Henry Ford. I would like to acknowledge the rest of the project team, my co-resident, Dr. Pasovic, and our faculty supervisor, Dr. Krayam. The area of improvement we identified is the lack of standardization in patient handoff when a patient is transferred to KINGSWOOD Hospital. To get an idea about the volume of admissions we're looking at, the Agency for Healthcare Research and Quality, or AHRQ, estimates that from 2005 to 2014, the number of inpatient stays for mental health and substance use increased by 12.2%. This is estimated to be more than 1 million patients per year in the United States admitted to a psychiatric hospital. So let's talk about why handoff is important. Studies have shown that communication breakdown is implicated in many preventable patient care errors, up to 65% of sentinel events, according to the Joint Commission. A study published in 2014 in the New England Journal of Medicine found that using structured handoff between shifts decreased preventable adverse events by 30% and also increased inclusion of pre-identified elements. So what makes a good handoff? It needs to be written with predefined elements. One study found verbal handoffs have the highest risk of miscommunication, followed by non-structured written handoff, like using a blank sheet of paper, followed by structured written handoff, like using a paper template. So, how are psychiatric hospitalization handoffs unique? For starters, it is multidisciplinary. Patients often have time-sensitive comorbidities which require care by multiple teams. Another important aspect is that different settings use different safety rating scales, which can hinder communication. For example, during shift change handoff at KINGSWOOD, we used a dynamic appraisal for situational aggression, or DASA, to communicate potential for aggression. But this information might not be available from the emergency room which the patient is coming from. Another good example is suicide rating scales. Finally, psychiatric hospitalizations often involve different hospital systems with incompatible EMRs. So, if an item is missed on handoff, you cannot simply look that up in the chart. We searched the literature, but did not find studies on inter-hospital handoff, especially as it applies to psychiatric hospitalizations. So, what did we hope to accomplish with this project? The goal was to standardize the handoff report by creating a list of predefined elements which were required for each patient coming into KINGSWOOD. This was performed using a simple tool, creating a paper template with a matching template on the EMR. The goal was measured using chart reviews to count the adoption rate. So we searched for the EMR template on each patient chart. The information we included was highly relevant. Only items which are safety or action-oriented were included in the handoff template. And finally, the project had a clear timeline, monitoring the adoption rate over 6 months. This is a diagram of the admission process at KINGSWOOD and where our intervention fits in. Starting on the left here, once the intake department obtains approval from the attending physician, the emergency room nurse provides a handoff report over the phone to the nurse at KINGSWOOD. The patient is then transferred via ambulance, and the KINGSWOOD nurse makes an initial assessment of the patient upon arrival. After that, the nurse calls the physician to give a second handoff report. So, given the pivotal role the nurse at KINGSWOOD plays in this process, our intervention revolved around that individual. Because of this, the nurses were the care champions of this project. So these are the handoff elements we included, and each item was chosen after a discussion with nursing, resident, and attending staff. As you can see, an affirmative answer to any question here will lead to a direct action, such as starting pain management, staff monitoring, or trending labs. And this is what the results look like. As you can see, we saw a sustained adoption rate even at 6 months, which is remarkable. Of course, ultimately the goal is 100% adoption, because even one misinformation can potentially lead to an adverse outcome. So, how do we move forward with these results? Most importantly, this is an ongoing project. Nursing management reviews charts periodically to make sure all nurses are using this handoff format. And this is an iterative process. We have received very positive feedback so far. One interesting feedback is that the emergency room nurse giving a report from the outside facility sometimes doesn't have all the information we ask for, because they just started their shift. This highlights the importance of having a standard handoff report. We would like to maximize efficiency by matching this inter-hospital handoff to the inter-shift handoff already being done at KINGSWOOD, so that it will not seem like this project is yet another form for the nurses to fill out. The potential for future direction is broad, but what we are most excited about is that now we get the same amount of information for each patient coming into KINGSWOOD, regardless of where they came from. And that information helps us act in an appropriate and timely manner to best serve our patients. Thank you very much for your time.